record. There we go. So just for everybody on the phone, my name is Eileen Michelli, and I'm with the Marfan Foundation. This is our Prepare for Victory virtual medical symposium series. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on genetic aortic conditions from our professional advisory board and other leading medical experts on these conditions. And I want to thank our funder, which is the Chu and Chan Foundation, for making these webinars possible. So before we get to our presentation tonight, I want to welcome Michael Weimer, our president and CEO of the Marfan Foundation, and he is here to welcome you all.
Thanks, Eileen. Good evening, everyone. I really just wanted to say hello and thank you for joining us this evening. You're in for a treat. Dr. Lacro is a great physician, wonderful volunteer leader, member of our professional advisory board. And next year, he will be one of the hosts as we bring the annual conference to Boston next July. So we have a busy year ahead, but tonight you have a wonderful opportunity to learn about Marfan, vEDS, LDS, EDS, and I will turn it back to Eileen. But thank you all for joining. I look forward to listening this evening.
Thank you, Michael. So as you know, as Michael mentioned, we're going to be talking about children's heart issues in Marfan, Loeys Dietz, and vascular Ehlers-Danlos syndrome. If you have questions during the presentation, please type them in the Q&A box, which you can see on your screen. We're going to leave time at the end to answer those questions. So we are thrilled to have Dr. Ron Lacro with us tonight. He's a member of our professional advisory board, as Michael just said. Dr. Lacro is a pediatric cardiologist at Boston Children's Hospital. He's director of the Cardiovascular Genetics Clinic there and the Marfan Syndrome and Related Disorders Program. And he's not only a medical expert, but he's also a true champion for our community. And he is always around, whether it's at formal events, informal events, and available to talk to all of you and give his expertise for the Marfan Foundation. So now we're going to pass this over to Dr. Lacro to take us through this presentation. So are you able to get the remote? Let's see. There he is. Okay, great. Although I'm not hearing him. Ron, we can't hear you, so.
Hi, can you hear me?
Yes, now we hear you. There you go.
Hi, great. Yeah, you can't hear me because I was on mute. Good evening, everybody. It's a thrill for me to be on this call with all of you. I'm going to talk about heart issues, specifically applying to children with Marfan, Loeys Dietz, and vascular Ehlers-Danlos syndrome. I think many of the topics we're going to talk about today will apply to other connective tissue conditions as well. So if you are yet without a diagnosis, some of this information hopefully will be helpful to you. So in terms of the outline for my presentation today, first I'll just give a brief introduction to the main syndromes that we're talking about today, give some basic information about cardiovascular anatomy, just put everybody on the same page, talk about some common cardiovascular findings in these connective tissue disorders, move on to imaging techniques, echo, MRI, and CT scans, and hopefully decipher any questions that you might have about aortic root Z-scores as a means of following your aortic root size. Talk a lot about medical therapy, a little bit about surgical therapy, and then spend some time talking about physical activity and exercise for people growing up with connective tissue conditions. At the end, I'll talk briefly about an FDA warning recently about fluoroquinolones, which is an antibiotic, and then hopefully leave enough questions, enough time for your questions and my answers to them. So just briefly, Marfan syndrome, probably the most well-known of the connective tissue conditions, recognized as early as 1896 by French pediatrician Antoine Marfan. He recognize the skeletal features that you can see in this 5-year-old girl named Gabrielle. Later, dislocation of the lens, and you can see the eccentric position of the lens here was linked with the skeletal abnormalities. And then eventually aortic enlargement or aortic aneurysm and a tear or dissection of the aorta became part of the syndrome. Here's an echocardiogram showing not only a large aortic root aneurysm in a 17-year-old boy with Marfan syndrome, but also mitral valve prolapse. This is a CT scan picture showing a very large aortic aneurysm, again in a patient with Marfan syndrome, just showing how a CT scan can easily show the aortic structures. The next slide, if you're a little queasy, you might want to close your eyes on, but this is the same aneurysm at the time of surgery. So you can see the aorta is very large and the wall of the aorta is very thin. The next picture is actually going to show the aortic aneurysm after the surgeon has cut into the aneurysm. And you can see we're looking down into the aortic valve. And this tissue here that I'm outlining with my pointer is actually the valve tissue. And this here is the wall of the aorta, which really should be attached to this side here so that the inner lining of the aortic wall has separated from the middle and outer layers of the aorta. And that's what a dissection is. So this is a life-threatening aortic complication that we see in all of our connective tissue conditions, and the one that we try to prevent if at all possible. So Marfan syndrome, again, is a combination of skeletal findings, eye findings, and aortic enlargement. Now, although Loeys Dietz obviously has been around for much longer, it took until 2005 for us to actually recognize the syndrome as something different from Marfan syndrome. Marfan syndrome being a condition affecting FBN1 or caused by mutations in the gene for FBN1. With Loeys Dietz, many patients who had Loeys Dietz prior to 2005 were followed in connective tissue programs and thought to have perhaps atypical Marfan syndrome, but it was recognized in 2005 by Drs. Loeys and Dietz that this indeed was a distinct syndrome with a lot of overlap with Marfan syndrome. From a cardiovascular standpoint, there were very similar findings in terms of aortic aneurysm and mitral valve prolapse, but the aortic disease tended to be more aggressive and diffuse. There was generalized arterial tortuosity or twisting of vessels, which I'll show examples of. And then there were other non-cardiovascular signs that were typical for Loeys Dietz. And here, some typical pictures of children with Loeys Dietz from the literature showing a different physical appearance from Marfan syndrome. Many patients with Loeys Dietz have abnormalities of the uvula. And it is more common for people with Loeys Dietz to have other congenital heart defects like bicuspid aortic valve or bicuspid pulmonary valve as compared to Marfan syndrome. One characteristic of Loeys Dietz is the tortuosity or very curviness of the aorta and other blood vessels, and you can see a good example of tortuosity of the aorta in this patient with Loeys Dietz syndrome. And then the peripheral vessels beyond the aorta can also be very tortuous. Again, these are patients with Loeys Dietz syndrome with very tortuous arteries. These are neck arteries in patients with children with Loeys Dietz syndrome. And you can see the very straight carotid artery, but the very curly and twisty, tortuous vertebral artery. And this tortuosity can be seen not only in Loeys Dietz, but also other connective tissue conditions. And the more tortuous the vessel, we feel the higher the risk for aortic and other vascular problems. We now know that at least 6 genes can cause Loeys Dietz or Loeys Dietz-like phenotypes, and these are the genes listed here. In terms of vascular Ehlers-Danlos, here's a picture of Dr. Ehlers and Dr. Danlos. This, in contrast, is a syndrome that's caused by mutations or changes in the gene for collagen 3A1. And the major diagnostic criteria include arterial aneurysms, dissection, or rupture. And sometimes the vascular events, the ruptures, can occur even when without enlargement or aneurysm formation of the arteries. Other findings include problems with smooth muscle, including intestinal or uterine rupture. And unfortunately, not infrequently, the diagnosis of vascular Ehlers-Danlos syndrome is not made until at least one member of the family has had a major complication. These are some of the minor diagnostic criteria. Many of these other findings affect the skin and musculoskeletal system, but patients with vascular EDS can have easy bruising, either with minimal or no trauma, and they can also have early onset varicose veins. I want to make a point about all of these connective tissue syndromes. All of these P's apply, but I want to focus right now on two things. One, progression over time. It's very important in following, especially the cardiovascular manifestations of these connective tissue conditions, that we realize that things can progress over time, so that even if there is no cardiovascular findings at any given time point, if one carries the diagnosis of Marfan syndrome, Loeys Dietz syndrome, or vascular Ehlers-Danlos syndrome, it's very important to follow patients over time to watch for progression of these findings. And then lastly, making a diagnosis of any one of these syndromes is very important in terms of preventing serious complications. We all, or many of us, know that Jonathan Larson was the writer of several musicals, including the musical Rent. And unfortunately, he died just before Rent opened in New York of an aortic dissection. Unfortunately, nobody in the emergency room noticed that Jonathan Larson had some physical features suggestive of Marfan syndrome, and had we known that he had a connective tissue condition, he would have been treated very differently in the emergency room, and perhaps we would have survived the dissection and be still writing musicals today. So diagnosis, whether it's for Marfan syndrome, Loeys Dietz syndrome, or vascular EDS, is the first step towards reducing the risk and preventing major complications. Now, just some basic cardiac anatomy. This is simple, and most people already know this, but I wanted everybody to understand that the right side of the heart here supplies blood to the lungs, and the left side of the heart supplies blood to the body. And here we see the left atrium, the upper portion of the left side of the heart, the mitral valve here, which can develop mitral valve prolapse, and the left ventricle pumping blood to the aorta. Now, what are some of the common cardiovascular findings that we might encounter in a patient with Marfan syndrome, Loeys Dietz, or vascular Ehlers-Danlos syndrome? Probably the most important in many patients, certainly not all, is the enlargement of the aortic root or ascending aorta. In milder cases, we call it aortic dilation. An aneurysm refers to a very large aorta, and dissection is a tear in the wall of the aorta, and the larger the aorta, the higher the risk for dissection. Aortic regurgitation is leaking of the aortic valve, which is more likely to occur when there is aortic enlargement. Mitral valve prolapse here. So this is the left atrium and the left ventricle, and you can see the mitral valve here. You can see that the leaflets are very flexible and bend back towards the atrium, and there's leaking of the valve. And mitral valve prolapse is a common finding in all of the connective tissue conditions. All right. The valve prolapse can also occur on the right side of the heart and cause leaking of the tricuspid valve. I should mention that prolapse itself is not necessarily a bad thing. A valve can be flexible and bend and have unusual graceful motion, but the more significant factor is how much the valve leaks. So the more leaking of the mitral valve, the more significant the problem to the patient. As the mitral valve leaks, if the mitral valve leaking is significant, that would cause enlargement of the left side of the heart, which can be measured by echo, MRI, and MRI. We already mentioned arterial tortuosity. And here again are the pictures of the vertebral arteries in patients with Loeys Dietz. We did a study maybe 8 years ago now. And although this arterial tortuosity was initially described in Loeys Dietz, it turns out that patients with other conditions, including Marfan syndrome, can also have tortuosity. And the degree of tortuosity, in this case, quite significant, is a marker for severity of disease. So we can take pictures of the neck and measure the degree of tortuosity of the vertebral arteries and estimate the risk for complications of blood vessels and the aorta in patients not only with Loeys Dietz, but also Marfan syndrome and other connective tissue conditions. Peripheral artery aneurysms, these are aneurysms or enlargement and tears of arteries beyond the aorta. They can be in the neck, the brain, abdomen, are more common in Loeys Dietz syndrome and vascular Ehlers-Danlos syndrome than Marfan syndrome, but can also occur in Marfan syndrome. And then congenital heart defects or congenital heart disease are defects involving the development of the heart. So beyond mitral valve prolapse and aortic aneurysm, some patients with connective tissue disorders will have actual problems with the development of the heart. And these generally are present at birth. Congenital heart disease is more common with Loeys Dietz syndrome, but occasionally can be seen in patients with Marfan syndrome and Ehlers-Danlos as well. Let's move on now to imaging techniques. How do we measure the aorta or evaluate the function of valves and the function of the muscle of the heart? Most commonly, we use echocardiography or ultrasound, and the names of the tests would be an echocardiogram or a sonogram. This test, which most of you probably have already had, or your child has, offers excellent visualization of the heart, the aortic root, and all the blood vessels that are close to the heart. It's less useful for imaging of blood vessels in the head and neck and other parts of the body. The quality of the imaging by echo is dependent on the age of the patient, the size of the patient, whether or not there are skeletal issues such as a pectus deformity, and also patient motion. So a very mobile toddler, for example, will have lower quality imaging than someone who is cooperative and can lay still. The advantage to echocardiography is that it's very widely available. It's easy to perform. Most patients can tolerate it pretty well. And so echo is almost always used and is best for initial diagnosis and ongoing management. We use CT or computerized tomography because it can give better visualization of all of the blood vessels, including peripheral blood vessels in the head and neck, for example. And it's a useful tool when looking for things like tortuosity or dissection or tears in blood vessels beyond the aorta. The advantage to CT is it's generally widely available. Most hospitals do have CT scanners. This exam is very quick. The modern scanners now can do a CT scan in a matter of seconds or even a fraction of a second, and is generally well tolerated. Although the amount of radiation is much lower in the modern scanners, it does still use radiation. And so for children who need repeated serial examinations over many years, we try to avoid radiation and CT as much as possible. But in the case of an emergency, for example, when someone presents with chest pain and the question is there an aortic dissection or not, the CT scan is the best test. And then finally, we have MRI. So the MRI scan, again, basically can give the exact same information as the CT and probably even better information about the heart itself. So we can see blood vessels, look for tortuosity, rule out a dissection with an MRI. It's not available in every hospital. It does take a lot longer than a CT scan, but it doesn't use radiation. So it uses the properties of the body and magnets to image the different tissues. So it is a very useful technique, especially in growing children where the need for serial studies over a long period of time is significant. So MRI is best for long-term follow-up, for looking at peripheral vessels, and also when the echo pictures are not adequate to answer all of the questions. In reality, we use a combination of echo, CT, and MRI over the course of one's lifespan. And it's very important that the measurements that we get are done in a very consistent fashion, ideally in a single center with lots of experience with patients with connective tissue conditions. And it's very important to compare to prior studies and follow trends over time. Now, what about those aortic Z-scores, aortic root Z-scores? In adults with Marfan syndrome, Loeys Dietz, or Ehlers-Danlos syndrome, most of the medical and surgical decisions are based on the absolute dimension. How big is the aorta in centimeters, for example. However, in growing children, there are limitations to using absolute dimension alone. For example, an aorta in a 3-month-old is going to be a lot smaller naturally than an aorta in an adult. So the Z-score can help us to understand how, what should the aortic size be for any given body size. And we can use the aortic root diameter Z-score, or ARZ, correcting for body surface area, which is basically body size. And this allows us to assess the severity and progression over time. So if the Z-score stays the same, that means that the aorta is growing in a growing child in proportion to the rest of the body. If the Z-score is increasing, that means the aorta is growing faster than the rest of the body, and this should raise some concern. So here's a plot of various aortic root measurements over time in a patient that was followed here at Boston Children's Hospital from age about 4 to at least the more recent exam at almost age 25 years. And what you see in the blue lines here is what would be expected, what the expected aortic measurement would be for most people. And 95% of people will have aortic measurements within the 2 skinny lines, and the average is the dark line in the middle. And here you can see that most of the measurements in this particular patient have been just a little bit above the line, meaning that there has been a mild aortic dilation that has stayed mild over the course of 20 years. And you can see here on the graph of Z-score over age that the Z-score has basically been bouncing between 2 and 3 for many years. And this is a typical pattern for someone who has mild aortic root dilation. The aortic root Z-score stays about the same. The aorta keeps growing in proportion to the patient. In this patient here, another patient with more moderate aortic root dilation, you can see the measurements are slightly higher above the line, and the Z-scores are in the 4 to 6 range. Skip that one. In this case, we have a child with more severe aortic root dilation followed from birth. Oops. What happened here? Here we go. Sorry about that. And you can see in this patient, the Z-score has gradually increased over the course of many years. Can you hear me now?
Yeah, we hear you and we see. Go ahead.
Okay, great. So I'm sorry about that. So here in this patient, again, followed from birth to age 20s, you can see a gradual increase in Z-score to severe levels. And then, of course, the aortic root is normal size after surgery. This is a rare case in a child who has the so-called neonatal or infantile Marfan syndrome, where the aortic root was rapidly growing in the first 3 months of life. So you can see that the Z-score was 7.5 right at birth, and by 3 months of age, the Z-score was 15. This is very atypical, but made us worry quite a bit, and there was repair of the aortic root at 3 months of life. So what are some common things to think about it with aortic root Z-scores? Z-scores in the 7 or higher range are pretty uncommon. For most patients, the Z-score, aortic root Z-score, generally stays about the same or slowly increase. And so for most patients with Marfan syndrome and Loeys Dietz syndromes, we expect the aortic root Z-score to stay in the same or slowly increase over many years. But again, the important take-home message is in growing children, despite a stable Z-score, the aorta continues to get bigger. All right, what about medical therapy? So there are two basic classes of medications that we use: beta blockers, beta-adrenergic receptor blockers. Most of them end with olol. So atenolol is one of them. Propranolol is an older form. And the beta blockers all act by blocking the effects of adrenaline or epinephrine. And the physiologic effect is to lower the heart rate and lower the blood pressure. And we believe that lowering the heart rate and lowering the blood pressure reduces the rate of growth of the aorta in people who have connective tissue conditions that are susceptible to aortic dissection. The other class of medications more recently introduced, so-called sartans, losartan, irbesartan, and other sartans, blocks the action of angiotensin II. And the effect of this medication, so it doesn't block adrenaline, but it relaxes blood vessels and thereby lowers blood pressure. So we don't see the drop in heart rate, but the effect of both of these medications is to lower the blood pressure. Probably the biggest study looking at the efficacy of these medicines for people with connective tissue conditions was a trial that we did a few years ago for people with Marfan syndrome. And we've known for quite some time that beta blockers slow the rate of growth of the aorta in people with Marfan syndrome. So in untreated patients compared with treated patients, the slope of the curve is lower in those that receive beta blockers. And the tendency is for better survival in patients who are treated with beta blockers. More recently, a mouse model was introduced showing that losartan, the other kind of medicine, can rescue the aortic phenotype. And I don't have time to go through all of these pictures, but at least in the mouse model with Marfan syndrome, treatment with losartan normalizes the aorta. So this is what a normal aortic mouse aorta looks like, and this is what a mouse aorta looks like after treatment with losartan. This is what it looks like untreated. So you can see that there's a vast improvement in the appearance of the aorta with treatment with losartan. And there was some evidence, and again, I'm having to skip some of these slides, but there was some evidence treating some kids with severe Marfan syndrome, showing that losartan was also potentially very effective in controlling the rate of growth in the aorta. So what the trial did was basically compare the rate of growth of aorta with atenolol, which is a beta blocker, to losartan, which is an angiotensin receptor blocker. And we basically recruited 608 patients between the age of 6 months and 25 years who all had Marfan syndrome and had aortic root Z-scores greater than 3. None of them had had previous aortic surgery. And we randomized them, meaning half of the patients were randomly assigned to take atenolol for 3 years, and the other half were randomly assigned to take losartan. And you can see here, the groups are roughly divided in half here, 303 and 305. But most of the patients ended up with echoes at the very end of the 3-year trial. So the trial was successful in maintaining these patients in the trial. And here are the results of the study. So what we look like, or we're looking at, is a change in aortic root Z-score over the 3-year period. And the red is the atenolol and the blue is losartan. You can see that both drugs cause a decrease in aortic root Z-score, but there was no significant difference, p-value of 0.08, between the two drugs. So even though it looks like atenolol was a little bit better, statistically there was no significant difference between the two groups. And this is just a growth, looking at centimeters. You can see that the aortas were growing because these were mostly growing children, and the difference in the growth rate between the two groups was not significant. So we feel that both medications are effective, but one is not necessarily better than the others when we're looking at groups of patients taking the medicine. One thing that we did find, which was very important, is that whether you were taking losartan or atenolol, the younger the patient, the bigger the improvement in the aorta. So this strongly supports the idea of starting treatment with either of these medications younger rather than older. The older patients definitely had a benefit, but the younger patients had even a greater degree of benefit. There weren't very many dissections, surgeries, or deaths, and no difference between the two groups. And in terms of side effects, both drugs were pretty well tolerated, and maybe a small difference with some mild adverse events or side effects reported in the atenolol group. But in terms of major events or major side effects, there was really no significant difference. So we concluded that both drugs were effective to a similar degree, that both drugs were well tolerated, and that both losartan and atenolol seems to be more effective the younger the patient. Other trials have looked at the question of whether or not combination therapy, losartan and beta blocker in combination, is that better than beta blocker? And the results of these trials are mixed. Some trials have shown that the combination is better, and other trials have not. So it's hard to know exactly how to answer that question. And then secondly, there's a recent trial described using a different sartan, irbesartan, and in that situation, in the United Kingdom trial, patients who took both irbesartan and a beta blocker did better than patients taking beta blocker alone. There's not very much information about medical therapy for patients with vascular EDS. This is the results of a study that was published in Lancet in 2010. The study was done in patients in France and Belgium. It's promising in that it did show the blue is actually patients who were treated, and the red are patients who were not treated. Blue is better, higher is better here, so this is freedom from having events, things like arterial ruptures. There is some logistical problems with the trial, so I think we need to do more studies. But this study at least suggested that medication with celiprolol, which is a type of beta blocker, can be effective in reducing complications in people with vascular Ehlers-Danlos syndrome. All right. Okay. I'm not going to spend much time talking about surgical therapy because I'm running out of time. But what I would say is that the guidelines are more strict in terms of when to intervene with surgery in adult-sized patients and have to be tailored to the specific findings in any given child. That's what I'll say for that. Now, in terms of physical activity and exercise, there are many benefits to exercise. We all realize that. And I think that exercise can be beneficial to patients with Marfan syndrome, Loeys Dietz, and vascular Ehlers-Danlos syndrome, certainly for the social aspects and some cardiovascular aspects. But what is really safe for patients with these conditions, and how much exercise is safe? First, we have to realize that whatever recommendations we make should be individualized based on any given person's findings. So that some people will have a very large aorta and other people will have a normal size aorta. And so people with bigger aorta should have more restriction. And it also will depend on the underlying diagnosis, whether it's vascular EDS versus Marfan syndrome or Loeys Dietz. And there are also other non-cardiac reasons for restricting activity, things like lens dislocation, musculoskeletal problems, lung problems, and other cardiac problems not related to the aorta. So as I mentioned, people with very enlarged aortas will generally have more restrictions than people with normal size aortas. I think in terms of discussing exercise, I would encourage you to think about exercise in a couple different ways. One, is the exercise more dynamic, involving motion, running, swimming, biking? These kinds of exercise are probably more beneficial for all of us from a cardiovascular standpoint, and also associated with a lower increase in mean blood pressure, as opposed to more static or isometric exercise or strength exercise, weightlifting. These are associated with a much higher increase in blood pressure, and professional weightlifters have very large increases in blood pressure, which is dangerous for the aorta. So if anything, for people with connective tissue condition, I would lean more towards dynamic or motion type of exercise as opposed to strength exercise. And then the other concept I would differentiate is, are we doing the exercise or the athletics to compete? Is it involving very systematic and rigorous training? Are we trying to be the best, the fastest, the strongest? Or are we doing it for fun at a non-competitive level, light to moderate exercise for fitness and fun? I think recreational athletics can be applied for most patients, and competitive athletics should be avoided. Some basic questions. Again, I don't have time to give all of the evidence, but I can basically answer some of these questions, and then maybe in the question and answer I can provide more information. Question number one, can exercise lead to progressive enlargement of the aorta? The answer is yes. If you look at elite athletes, both strength athletes as well as marathon or endurance athletes, their aortas are bigger than in people who don't exercise to that level. Can exercise cause aortic dissection? The answer is yes. There are incidents of aortic dissection that occur either during or after exercise. How common is sudden cardiac death among competitive athletes? Fortunately, it's relatively uncommon. Obviously, very unfortunate when it does occur. And all of those rare events of sudden cardiac death among competitive athletes, about 1 or 2% of them will be related to an aortic event. And then, is there any evidence that lower levels of exercise are helpful or harmful to the aorta? There actually is some mouse experiments suggesting that low to medium levels of exercise actually help the aorta, whereas more moderate to vigorous exercise do not. So even the mouse experiments are suggesting that some exercise, mild to moderate aerobic exercise, can be beneficial to the aorta and to blood vessels. So to summarize, I would emphasize more dynamic, sort of running, walking, swimming type of exercise over strength exercise, and competitive athletics should be excluded, and focus should be on recreation and fun and fitness. And then my last thing will be about this FDA warning about fluoroquinolones that you may have heard about. So in December 2018, the FDA issued a warning against the use of these antibiotics in patients with genetic aortic conditions associated with aortic aneurysms, the very conditions that we're talking about today. So this is a very commonly prescribed class of antibiotics. Most of them, the generic names will end in floxacin. So moxifloxacin, ciprofloxacin, levofloxacin, ofloxacin. And this warning was due to the fact that a review of several recent studies show that people who have taken one of these antibiotics are twice as likely to experience an aortic dissection or aneurysm than those who have not taken one of these drugs. The risk is still relatively small, but it's higher than if for those patients who didn't take fluoroquinolone. So the FDA is requiring that we change the labeling for these medications. Certainly as physicians and providers, we should not be prescribing these medications to people with genetic conditions affecting the aorta unless there are no other treatment options are available. And if you are now taking one of these fluoroquinolones or oxacins to treat an infection, don't stop the medicine until you first talk to your provider. And certainly if you experience symptoms of a dissection, such as sudden severe chest pain in the chest, back, or abdomen, certainly seek emergency care, either call 911 or whatever the number is for the UK and other countries, or go to an emergency room immediately. So I will stop there, and hopefully we'll have some time for questions and answers.
That's great, Ron. Thank you so much. I'm going to grab the screen back from you. That was really outstanding. A lot of great information there. So before we go on to the questions and answers, I just want to talk for 1 second or 2 seconds about backpack health. Kind of follows all of what Dr. Lacro was talking about in terms of all the different kinds of testing and ongoing imaging and medications. Backpack Health is an app that you can download for free. They are great partners of the Marfan Foundation and have created this app especially for people with complex conditions like these genetic aortic conditions that we've been talking about. It's a way to compile your health records for you and your family members. It's safe, secure, comes in 6 languages, and allows you to share certain information with others in your circle as you wish, whether you need to get certain information to the school nurse or you have an emergency card that that you could share with people who may be taking care of your children, whether they go away with grandma and grandpa. At least the information is there for your kids. They don't have to carry binders around. Everything's on the app. Also, if you join our registry through the app, the Marfan and related conditions patient registry, that will help research in the future too. So this is all on our website. You can access it. It's free, it's easy, it's safe. And so I want to make sure that I let you know all about that. Just a couple of slides here to show you that you can your health information's there, you can advance research, and you can join the registry through our website. That little backpack health icon that you see there, you'll see that on our website. Just click on that. So now we'll go to the questions and answers for Dr. Lacro. First one, going right to it. At what Z-score would you advise starting losartan? This particular person says that her son is 3 years old and has a Z-score of 2.16.
So first of all, you recognize that a normal aorta will have a Z-score somewhere between -2 and +2. So a Z-score of 2.2 plus 2.2 is just above what would be considered normal. There's some difference of opinion here. Some providers feel that any patient that carries a diagnosis of Marfan syndrome or Loeys Dietz should be treated with losartan or atenolol, whether or not the aorta is enlarged. It depends on some factors. I do have patients who have Z-scores very close to normal. So Z-scores less than 3 that we're following closely, that we wait to start medication. So there is a difference of opinion in terms of whether or not your son requires treatment. He definitely needs to be followed with echocardiograms at least once a year. And if the Z-score tends to creep up, then medication should be started. Now, I should say that it really doesn't take very much of a difference in measurement to change your Z-score. So don't get worried if the Z-score goes to 2.5. That's really not a big change between 2.1 and 2.5. And it really is sort of following those measurements over a long period of time. Eileen, I forgot to mention, you asked me to talk a little bit about the recall.
Yes.
On losartan. So as many of you have heard, or a number of the losartan, the angiotensin receptor blockers, the ARTANs, have been recalled because of a contaminant in the preparation process for the medication. We think the medicine itself is safe, and so it really depends on which manufacturer prepared your particular medication. So many patients are able to continue to take their losartan or irbesartan because they're not affected by the recall. So speak to your provider, speak to your pharmacist, make sure that you're not using a preparation. At least as of now, we've had very few of my own patients that have been affected by the recall. And in the rare exception, we just switched to a different preparation.
Thank you for that. We are getting a lot of questions about that. What about combining losartan and doxycycline? Somebody says they've read that can reduce aortic aneurysm size. Is that, is there evidence of that?
So as far as I know, the doxycycline studies have been only performed in mice. I'd be happy to review other studies where it has been successfully shown to be effective in humans. So yeah, in the mouse, in certain strains of mice that have Marfan syndrome, treatment with antibiotics can reduce the aortic growth. And the theory there is that it's acting as an anti-inflammatory in the process. But I have not been using doxycycline in my human patients.
Okay, thank you for that. This is not about the heart, but close to the heart and cardiovascular system. Can you just talk briefly about lung problems in Marfan? How common are lung problems in Marfan, and how is restrictive lung disease diagnosed?
Yeah, so there's a couple different issues with, or at least a couple different issues with the lung. First, people with connective tissue conditions can have a collapsed lung or a pneumothorax, where air from within the lung escapes the lung and goes around the lung and can collapse the lung or compress the lung. In Marfan patients, the rate of pneumothorax is probably in the range of 10 or 20%. So most patients with Marfan syndrome don't get a pneumothorax. And pneumothoraces can be seen in a number of different connective tissue conditions. In terms of restrictive lung disease, so there are lung problems, and I presume that we'll have a webinar on lung issues if we haven't already had one. But it is an issue that we can have sort of the size of the lungs can be affected, sometimes related to the pectus deformity or scoliosis, so there can be restriction to the size of the lungs, as well as asthma-type symptoms. And that's really dependent on the patient. So if there's any concern, see a pulmonary specialist, and usually pulmonary function tests. I think Stephanie is referring to that. Can diagnose those kinds of lung problems.
Great, thank you. While we're waiting for other people to put their questions in, let me just ask you, people are afraid of aortic dissection, obviously. How common is that in children? Is that something people have to worry about?
Fortunately, for most patients, aortic dissection is not an issue during childhood. Now, there are always exceptions to that, and it does depend somewhat on your underlying genetic diagnosis. So patients with vascular EDS and Loeys Dietz are probably as a group are at a higher risk than people with Marfan syndrome. And much of the risk is dependent on the size of your aorta. So for most patients who have mild or even moderate enlargement of the aortic root, the risk for dissection during childhood is pretty low, but not zero.
Right. Okay, great. Can you talk a little bit about a safe heart rate when the child is on losartan, or I guess even on a beta blocker? What's the safe heart rate for a child, when they're exercising? What are the guidelines for that? Yeah,
so the issue with heart rate is a couple different ideas. One is that a beta blocker actually lowers the heart rate. And so we use the heart rate as a means of measuring how effective the medicine is. And in the Marfan trial, we actually did Holter monitors where we measured the heart rate over a 24-hour period. If you're on a beta blocker, or if one is on a beta blocker, then your heart rate really shouldn't be as high as people who are not on a beta blocker. The heart rate that we would expect would also depend on age and conditioning, et cetera. So it's hard to answer with a specific number. But I think if beta blocker is the primary treatment that we're using for trying to control the blood pressure and control the rate of growth of the aorta for any of these connective tissue conditions, then the heart rate should be pretty slow at rest. And with exercise, mild levels of exercise should not be as high as someone who's not on a beta blocker.
And what about if the child is on losartan as the primary?
Yeah, so if a patient's on losartan, we don't expect the same drop in heart rate just because of the medicine is effective. So losartan doesn't intrinsically slow your heart rate. So your heart rate will be the same on losartan as anyone who's not exercising. with exercise as anyone who's not taking losartan.
So how high can it go? Like what's safe for those kids?
Again, it's hard to give a sort of one size fits all answer. I think, you know, in terms of, I mean, maybe the question, maybe the reason for the question is how hard should my child be exercising? Maybe that's a better question, and this is true for both medications. It's probably better to sort of kind of qualitatively measure your level of exertion, and so that if you are exercising at such an extreme level that you can only last, you know, 10 seconds or a few minutes, then you're clearly over-exercising. Whereas if you're exercising at a mild to moderate level and can walk or swim or bike for 20 or 30 minutes at a time, then you're probably sort of exercising at a safe level. I think the perception of exertion is probably better and easier than trying to chase a heart rate.
Yeah, I think it goes back to what you were saying, you know, doing it for fun or going all out to win at something, you know.
Right. And I think it's really, really important distinction that I start talking to my patients who are children at a very young age, you know, at first, obviously asking parents questions, you know, and some patients are challenging because they're very naturally competitive. And those are the hard ones. And you know, so to sort of redirect, you know, sort of naturally competitive children to sort of enjoying exercise at recreational levels can be a challenge, but I think it's important. It's important and difficult, but important discussions to have with children and families with connective tissue conditions.
You know, what I'll do is when I send out the link to everybody, I'll also send you all the link to our physical activity guidelines, because it simply explains all of what Dr. Lacro is talking about tonight, and you know, explains some of the gray areas and also what the doctors worry about. So you can make your own decisions with your own doctor based on your situation or your child's situation, but you can, it gives you some of the thinking behind what the recommendations are. So, you know, there aren't hard and fast rules, but there are some really great guidelines from the doctors with experience. So I will send that out to everybody. Let's see, lots of questions coming in now. Let's take a question here about vEDS. You know, we talked about MRI monitoring, but for vEDS, I need to have monitoring from head to pelvis. So what about the scheduling of MRI monitoring from head to pelvis? And is it different for Marfan, Loeys Dietz, and vEDS?
Yeah, so for most patients with Marfan syndrome, you know, the likelihood that we're going to see a peripheral artery aneurysms, one in the brain or abdomen, is much lower than it is for vascular EDS or for Loeys Dietz syndrome. My current protocol is to do MRI monitoring from head to pelvis for patients with vascular EDS and Loeys Dietz syndrome about every 2 or 3 years. That, you know, there are some things that sort of modify how I think about that. So if I find something that's abnormal, so if there's already an enlargement of a vessel, I'm more likely to do it more frequently, maybe 1 or 2 years rather than 2 or 3. If there's a very strong family history of peripheral vascular aneurysms and dissections, I'm more likely to screen more frequently. Also, you know, if there's a Marfan patient that has a peripheral aneurysm, that patient will have much more frequent screening than most Marfan patients. So it really sort of depends on the family history, what we found on the initial MRI, how big the aorta is, whether they have tortuosity. We know that tortuosity of the vertebral arteries, the more tortuous those arteries, the more likely that there's going to be an event, and that could be an aortic event or a peripheral event. So patients with a lot of tortuosity, I image more frequently as well.
Okay, great, thank you. Here's a question about minimally invasive heart surgery to repair valves. And she's wondering if it might be also possible to use minimally invasive methods for aortic root repair, you know, so that many of these kids would not have to go through open heart surgery.
Yeah, I mean, I think there is some work looking at minimally invasive work for the mitral valve, but not so much for the aorta right now, because in patients with connective tissue conditions, we have to replace the whole aorta, and that cannot be done with a minimally invasive procedure. Depending on what the mitral valve looks like, depending on the surgical skills of the surgeon and the preference, you know, I can foresee, you know, more mitral cases being done with quote unquote minimally invasive procedures. But it really depends on, you know, what the valve looks like. Many of these valves, particularly in patients with sort of early presenting or neonatal Marfan syndrome, can be difficult to repair. So certainly in those cases where patients are young, you know, these surgical techniques are not going to be applicable.
Okay, great. Thank you for answering that. There are a few more questions. I think we're going to hold on to those so that Jan and our help center can answer them, and with your help, Ron, if she needs as well. I just want to say a few things before we wrap up at 8 o'clock. Our next, this was really, really incredible, and we're going to go to the other end of the spectrum for our next webinar, Aging Issues in Marfan and Related Conditions, with Dr. Juan Bowen from the Mayo Clinic, and that should be a really great, great webinar as well, and that's May 6th. And you can do that on our webinar, on our website. You can do it at marfan.org, patients and families, and then virtual medical symposiums you see right there. Underneath that is the empowerment series, which is more webinars about more quality of life type of issues. But there's still lots going on in our world the next few months, and I would be remiss not to bring all these up. It's just such an exciting time for us all. Our 35th annual conference is coming up this summer in Houston. A lot of great activities, medical information, opportunities to connect with other people, programs for kids and teens, a special track for vascular Ehlers-Danlos, and a special track for Loeys Dietz syndrome also. So that is going to be an amazing event. We have health fair appointments and scholarships, and the applications for those are due April 15th. So if you are considering applying for a health fair or would like to apply for a scholarship, you have a few more days left to do that. So go to marfan.org. It's all there. We're going to be in Houston, Texas, and they do everything bigger in Texas. So this is really going to be an amazing conference. We're going to be all over the country in the next couple months as well with our walks, our regional symposiums, and also our Camp Victory for Kids. So that also is all on our website. Almost wherever you are in the country, there is something for you. So we do hope to meet a lot of you the next few months for sure. And I also wanted to take a moment just to mention, if any of your kids are going into the hospital, we do have a program to provide support for them and to, you know, cheer them up while they're there. I mean, the Marfan Foundation family is always there for you and your kids. And this is a program started by these two girls on the left, Sydney Lerman, who has Marfan, and her sister Carly. And they they raise money, and then they create baskets and boxes to send to kids in the hospital who have Marfan or one of the related conditions. And so there's a place on our website where you can fill out some information and tell us what's going on with your child, and we will get Sydney and Carly all your information, and you will get a fun little box. And there's Kelly on the right, who loved the box that she got from the Lerman program. So please take advantage of it. It's here for you guys, and you know, whatever we can do for your families, we're here for you. And then finally, as I said, Jan, the nurse in our help center, is a wonderful resource, and she's going to help with these questions that we did not get to tonight. And she's obviously there for you whenever you need. The best way to reach her is really through marfan.org, ask a question, and she will be able to answer your question, consult with our professional advisory board. If she's not able to answer it herself, consult with our Chief Science Officer, Joe Grima, who also is a great resource for her and for all of you. So we're here for you, and we hope that you can take advantage of all these opportunities to learn and to meet each other, and, you know, ask us whatever you'd like. And if you have other suggestions for these webinars, we are glad to hear those as well. So it's 8 o'clock, so I want to thank Ron Lacro for this amazing presentation tonight. So much information in such a short amount of time. I know you could do another hour easily, but we appreciate the time tonight and all that information that you shared. And Michael, thank you for joining us tonight as well. And thank you to everybody who has logged in. So I will get back to you on some of the questions in the chat because I see some coming up in there. And thank you all and hope to see you on another webinar. Good night.
Good night.